Welcome, everybody. My name is Marty Mascari. I'm with the North Central Texas Area Agency on Aging and the North Central Texas Aging and Disability Resource Center, which is a project under the Area Agency on Aging. And we're blessed here again with Hollie Glover with the James L. West Center for Dementia Care in Fort Worth for our incredible partnership series. And today we're going to talk about alcohol-related dementia, malnutrition, and medication interactions and how they affect the brain. But before we get started, we're going to talk a little bit about CEUs. And so if we could go to the next slide. So the CEUs for today are available complimentary for licensed nurses, social workers, licensed professional counselors, and also certificate of attendance if you're wanting or needing one of those. The requirements are the same for all of those. You must attend the complete live webinar. And really that means you can't really miss more than 5 or 10, really on a 1-hour webinar, it really should be not more than 5 minutes that you should be missing in order to qualify for these, for the CEUs. You also will be required to complete the SurveyMonkey evaluation form that will go out in the first follow-up email that will go out today, probably this evening sometime. And that survey evaluation will be available to you for 7 days until May 17th when it will close. And once it closes, we don't reopen it. It's not easy to do, and it's just too time consuming. So you're really required to get that done within the 7 days. The CEU certificates will be emailed to the email address that you provide when you fill out the form. The SurveyMonkey, and give them about 3 weeks after the 17th to get those certificates out to you. If you don't have it by then, feel free to email me or Jamie and we'll get that out to you or find out what's going on. In addition to that, for our funders at the Area Agency on Aging, we also will have a Google survey for you to complete. It should pop up for you as you close out of the webinar. If it doesn't, you'll also receive that in the follow-up email that will go out later this evening. So just so you all know, for any of you that are new, there will be a second email that goes out in about a week that will have the link to the recording of today's presentation, and you're more than welcome to share that with anybody that you might feel could benefit by it. So at that, I'm going to turn it over to Hollie and let Hollie have the floor.
Thank you, Marty. Great to be back again, as always. So today we've got a really interesting topic. And again, over the next few months, I hope that you will come back and be with us each month as we look at some of maybe the lesser known types of dementias. Remembering, those of you that do these with us on a regular basis, there are over 130 different kinds, types, or forms of dementia. So today we're going to look at alcohol-related dementia, malnourishment, and medication interactions and how they affect the brain. So this is a little bit of information about the James L. West Center here in Fort Worth. And I know we've got people from all over the United States and all over the world here with us here today. The James L. West Center we are long-term care. We are a nursing home, but we're a little bit different in that we are 100 beds and all we do is dementia care. The other thing that makes us really unique is that we have an education department. Jamie, who many times is on, she's not on today. She created this education department 10 years ago. I've been on here with her for 4 years, and this is all we do. We get to teach, and we go to conferences and conventions. We teach all over the United States, and then I get to run some fantastic support groups. And I've actually got 4 support groups, 2 that meet monthly and 2 that meet weekly to help those who are care partners of those with dementia. So we provide residential respite care. We have a day program and we do caregiver education, and we've been doing it for 29 years here in Fort Worth. So for those of you who will be getting your CEUs, here's the course outline and the course objectives. We got to have that in there, of course. But let's start looking at some statistics. So as we are talking about these different types of issues, alcohol, malnutrition, and medication interactions. Let's just start with some normal age-related changes. And again, those of you who've been on the programs know that we've talked about at length before that there really isn't an age-related memory loss. There's age-related changes, but there's not age-related memory loss. Contrary to what some commercials on TV may say, there's age-related, we're going to slow down, but we really should not have memory loss. But let's look at some things that do change because our brains age just like the rest of our bodies age. So if you'll look here, one of the things that sometimes we don't take into consideration, our weight. As our weight goes up and down, that affects how much medication older adults need and how long those medications stay in the body. So especially if we're an adult child taking care of our parents, this is some of the things we've got to think about when we first start seeing some issues, especially if we're seeing some cognitive issues. If they've got some comorbidities, circulatory system issues, kidneys, liver, all of those things are going to affect how fast those medications enter and leave the body. So unfortunately, in healthcare, we have the term, and I hate this term, but I didn't make the term. We have the term reversible dementia. I wish that it was called reversible memory loss, because people hear reversible dementia and think, oh boy, we can reverse it. It's really not the dementia that we're reversing. It's some memory loss that can reverse, because the reason that we have the memory loss is because of things like this, a medication interaction, or some of the other things we're going to talk about today. That's why we always start at the primary care physician. Always start at the primary care physician. So as someone ages, also in that second column, look at this statistic as well. When you stop to consider that 80% of older adults, and by older adults, we're talking 65 and older, have at least one chronic condition, and half of older adults have at least 2 chronic conditions, those are also going to come into play. Those are going to come into play with how well medications, how they're going to interact with each other. Keep in mind also, medications interact with food, other supplements, and we have kind of become a country of supplements. If you watch Dr. Oz, I know you're taking a lot of supplements. He recommends those supplements, and supplements can be good. We're going to talk about supplements. Natural products, alcohol and medications, alcohol and supplements. So what then happens? Some of these side effects can affect cognition, and they can be mistaken for dementia. Look at this that came out from the National Academy of Medicine. This is a group of medications that have been known to affect older adults' cognition. So we always want to talk to our doctor, other healthcare professionals about using prescription and over-the-counter medications or before we make any changes. We also want to see if there are other things that can be used. So we may have been taking these when we were in our 20s, 30s, 40s with no problems at all. But when we're 70s, 80s, 90s, may not be able to take them the same way. And those are things that many of us have taken for years. Look at the very first one on the list is antihistamines. And there's antidepressants and anti-anxieties, and we don't necessarily want to say to stay away from those at all. We're big proponents of making sure a person's on an antidepressant if they need it, but we want to make sure that they're on the right dosage and they're on the right medication for them. Sleep aids. Are they using an over-the-counter sleep aid? Are they using a prescription sleep aid? Are they using both? Those antipsychotics, muscle relaxants, the medications for urinary incontinence, and then the medications that's the antispasmodics. So this website, if you type in AGS, Beers criteria, and I just went there this morning to find the updated, and there is, so this one was updated in 2019, but what the information that we have on this slide is from 2019, and it is the most updated. But what you can do is you can go on there and it will have 2022, and it will actually list medications. So if you go to the website that's here, and we've got a whole page of resources for you that you'll get at the end of this. And again, the slides are in the chat. If you didn't already get them, you will get the slides. So don't worry about trying to write all of this down. You go to this website, and it has a list of medications that are worth discussing with healthcare professionals because they may or may not be safe or appropriate for older adults. And it is updated every year. And there's a 2022 list that's already up there. I went to it today and looked at it. So, and it's going to have it divided into, if you'll look there, it's about 1, 2, 3, 4, 5, avoided by most older people. Now, notice it says outside of hospice and palliative care settings. Why would it say that? Because when somebody is on hospice or palliative care, our goal is not curative, but comfort. Not curative, but comfort. Once a person goes on hospice care, we are not trying to cure their condition. There's no longer a cure for their condition. Our goal is comfort meds at that point. I've actually had people say to me, and this is just lack of education on their part, well, I don't want my mom getting hooked on some type of medication, and she's on hospice at that time. That's not what we need to be worried about at that time. At that time, we need to be worried about their comfort measures. That's why that says outside of hospice and palliative care. The second column that you'll see is avoided by older people with specific health conditions, and it'll actually tell you what health conditions, whether it's cardiac or whether it's kidney, whether it's liver. It also will have avoided in combination with other treatments because of drug-drug interactions, used with caution, and then dosed differently or avoided among people with, and then it's got the kidney function. So that's going to be a good resource to go to. And again, you'll have all of this information. So let's look at drug use and dementia. And I don't want you to get scared, and we've got some things in bold here, but I do want you to take note of this. Look at this first bullet point, and some of us may need to rethink what we're doing. The primary ingredient in Benadryl and the secondary ingredient in Tylenol PM. Look at this statistic. Is reported to have a cumulative effect in the human brain, which can cause as much as a 54% increase in the likelihood of dementia. Now, again, before we all go panicking, it did not show any relationship to cognitive impairment if used for 3 months or less, because those medications were meant to be used in short periods of time. Benadryl and Tylenol PM are meant to be used for short periods of time. Where we start seeing the issues is for people who have used them for 3 or more years or at higher doses. 3 or more years or at higher doses. The reason we put it on here is because we talked to an awful lot of folks that have used this as their nighttime medication for a long, long time, and now there's studies out about it. The active ingredient in Benadryl is an older antihistamine. There's newer ones out there that do not cause this type of damage. Make sure to talk to your doctor about this. If this happens to be a medication that you are taking on a regular basis, Benadryl and Tylenol PM are meant for short-term use. Another thing, long-term use of tobacco, even alcohol, which we're going to talk specifically about, and benzodiazepines have been shown to have negative cognitive consequences down the road. Whenever we talk about tobacco, there are many different health promotion programs designed to decrease tobacco, smoking, and harmful alcohol use and other drug use. Also, that chronic use of benzodiazepines has been associated with increased risk of cognitive impairment. But information related to dementia remains inconclusive. There hasn't been enough study done on that particular one yet. So let's look at the prevalence and the statistics of alcohol and drug-induced dementia. Now, I do want to mention something here because I know we probably have a lot of healthcare workers on here. And by healthcare workers, I mean anybody who works in the field, healthcare workers. We see more alcohol-induced dementia in healthcare workers than in any other field. Now, I want you to stop and think about why that might be. Over the last year, we've done several programs on resilience, burnout, compassion fatigue. Alcohol is easily available. Those of us who work in healthcare, lots of times when I talk about this, I turn my camera to where I don't have my background on, but you can see my wall, and my wall back here has my degrees on it. I'll say, why is it that people who work in healthcare oftentimes, or not oftentimes, but why is it that there's more people with alcohol-induced dementia that work in healthcare? Well, we've got those diplomas and we don't ask for help. And alcohol is easy and it's readily available. The alcohol abuse is also really common in people over the age of 65. 60% report regular drinking. Let's look at what defines binge drinking. It's 5 or more alcoholic drinks for males and 4 or more for females at the same time or within a couple of hours of each other on at least one day in the past month. And then heavy alcohol use is binge drinking on 5 or more days in the past month. Now let's look at a picture of a brain. And this is a brain of a normal 43-year-old and a 43-year-old alcoholic. Now, those of you who've been on our programs when we've shown the brain of somebody with Alzheimer's knows that it has a lot of atrophy. Look at that brain on the right. Alcohol kills brain cells. Some of the other things that happens: blurry vision, slurred speech, poor judgment, poor decision-making, and it can lead to permanent memory loss. It is a real thing. Alcohol-induced dementia is a real thing. It is shrinking the brain, having a smaller hippocampus. Now, it is caused by years of heavy drinking. We've just gone through, we're still going through, pandemic. We're not to the other side of it. Still the messy middle, not the new normal. 2020, effects of the pandemic. Prescriptions for antidepressants and anti-anxiety medications are up 34%. Alcohol use in women is up 41%, and in men, it's up 54%. It's what we're using to cope. It's what a lot of people are turning to cope. Some more statistics on alcohol-related dementia. That very first bullet point, it can be acquired if one gets intoxicated with alcohol regularly, because look at what it's doing to the body. Intoxication is depleting nutrients out of the body, and it's not just the brain, it's affecting the liver, the kidneys, and the pancreas. It is the most, I've got it in bold print, the most significant preventable factor in a dementia diagnosis, because this is not something we have to have. So we can prevent this. Some of the heavy drinking effects on the brain. Again, from the National Institute on Alcohol Abuse and Alcoholism, defines heavy drinking as 4 drinks a day for a woman and 5 for a man. Causes permanent damage to the brain. It can also lead to high blood pressure, an irregular heart rate, and stroke. That then is associated with vascular dementia. So a person can have what's called a mixed diagnosis. We've seen a new statistic very recently that said mixed diagnosis is the 3rd most common type of dementia now. Alzheimer's disease being number 1. Alzheimer's disease is the most common type of dementia, meaning under that big dementia umbrella, about 70% of all dementia is Alzheimer's disease. The newest statistic says that the 3rd most common type of dementia actually is mixed. Mixed means that a person has 2 types of dementia at the same time, at least 2. And it almost always, the 2nd one is vascular. Where somebody has something going on with the cardiovascular system, and it can be brought on by drinking. Risk factors. You don't have to be an alcoholic or a binge drinker to increase your risk for developing dementia. Just repeated binge drinking increases our risk. Just like long-term use of smoking, we know increases our risk. Smokers are at a very high rate of vascular dementia because they're at a very high rate of having a cardiovascular issue. Anything that affects our heart is affecting our brain. Let's look at some alcohol-related dementia symptoms. Here are some of the first ones, those memory problems. Most everybody thinks memory problems. Language impairment and inability to perform complex motor tasks like dressing. We may start seeing some nerve damage in arms and legs, and it's that peripheral neuropathy that we're seeing. Something a little bit different than we see in something like an Alzheimer's disease is the problems with the sensation in the extremities. Maybe being unsteady on their feet, which we see in most of the dementias, where most folks will get that dementia shuffle at one time. But they may have some sensation differences in their hands and feet because of neuropathy. High fall risk. Keeping in mind damage to the heart and to the liver. And there is also, when I mentioned to the heart, there is alcoholic cardiomyopathy. This is heart damage, and it may produce additional brain complications such as stroke or low blood flow to the brain. And then again, we have what's called a mixed diagnosis, where someone can have alcohol-induced dementia as well as vascular dementia. You may see impulsive and hostile behavior. Some of the other things on here: depression, anxiety, irritability. And these things can occur before you start seeing cognitive loss. Now, you may have heard of Wernicke-Korsakoff syndrome. It's like dementia. It's an alcohol-related dementia. It's a broad term that describes alcohol-induced brain damage that affects a person later in life, and the symptoms are varied. I've actually got a very short, I think it's about a 3-minute video that we're going to watch on it that I'm going to get to in just a couple of slides. That's it puts it in really simple terms. Alcohol prevents the body from properly processing this vitamin. So let me get to this next slide. And it's going to talk about Korsakoff's dementia. Alcohol and dementia are strictly related in this case, because too much alcohol prevents normal neurological functioning, which leads to dementia. So I want to make sure and get to this video. All right, let me have my video come up. Here it is. And this is going to describe it in a real simple way. This is something that if you need to teach someone about this, you can find this video on YouTube. So let's watch this real quick.
Another neurological disorder affecting memory is Korsakoff syndrome, which is caused by a lack of vitamin B1 or thiamine in the brain. This disorder is strongly linked to severe malnutrition, eating disorders, or especially alcoholism, because these groups often don't ingest or are unable to process all the nutrients their bodies need, including thiamine. Thiamine is important because it's responsible for converting carbohydrates into the glucose your cells need for energy. And it's especially important for the normal functioning of your neurons. At first, a person developing Korsakoff syndrome might have damage to certain parts of the brain, resulting in poor balance, abnormal eye movements, mild confusion, and/or memory loss. At this stage, it's actually called Wernicke's encephalopathy, which is the precursor to Korsakoff syndrome. If Wernicke's encephalopathy is diagnosed in time, then it's possible to reverse the damage, or at least prevent more of it. If untreated, however, the disease will progress into full-blown Korsakoff syndrome. The main symptom of Korsakoff syndrome is severe memory loss. And this symptom is often accompanied by confabulation, which is when the patient makes up stories, sometimes to fill in the gaps in his or her memory. Unlike AD, Korsakoff syndrome is not necessarily progressive. If diagnosed and treated, people can get better. People are often treated with thiamine injections or other medication, and they have to stay on a healthy diet and abstain from alcohol. And some people may also need to relearn some things. The effectiveness of this treatment really depends on how early the disease is diagnosed and how well the patient follows the treatment guidelines.
Perfect. All right, so some other causes that can happen. A person can lose vitamins if they are doing dialysis, if they have a metabolic illness. They can also have malabsorption of their vitamins due to anorexia, if they have had a GI surgery, bariatric surgery, if they are having IV feedings, or if they have been fasting, they can lose the nutrients as well. So to get a diagnosis of an alcohol-related dementia, that you have to have a really careful clinical history and a physical examination both. Because alcohol-induced dementia resembles other types of dementia, it cannot be confirmed with just a simple clinical history. Another thing, and this is important, so if you look at that third bullet point, patients cannot be diagnosed with dementia while they are in withdrawal or experiencing serious medical complications resulting from substance abuse like liver failure and GI bleeds. So this particular type of dementia many times is underdiagnosed because they don't recognize the alcoholism in the majority of elder patients. Another thing that happens is that families will say, just let dad have his drinks. Just let mama have her drinks. And we don't intervene and we don't step in, and more damage is done. Now at the bottom in bold, where with other dementias, we could have an MRI. Look at this. Brain imaging or other clinical studies are not helpful in distinguishing alcoholic dementia from other diseases. Neuropsychological testing can sometimes help clarify this diagnosis. You can't just have an MRI, look at it and go, that's alcohol-related dementia, like you can with other types of dementias. So you have to have a really good clinical history and physical examination. Treatment, look at the first one, sobriety. So possible inpatient rehabs or clinics for close monitoring. That's the first one, is sobriety. And then of course, doing that vitamin replacement with IV therapies and infusion, management of other medical problems and behavioral problems, ongoing attention to heart and liver functions. If we can get the person to stop drinking, I've watched this happen, watched it happen over and over again. The brain change caused by alcohol may be stopped. And sometimes we can have some small improvements. And we put there slow, small improvements of intellectual function, because I've had people who have alcohol-induced dementia were to the point that they couldn't walk anymore, didn't have very much speech left anymore. And as they came off of the alcohol and they dried out, and we had them in therapy, physical therapy, occupational therapy, they gained the ability to walk again. I've seen people do that. It's like a fog would kind of start to lift. A lot of the damage is done, but unlike an Alzheimer's disease or a Lewy body or a frontotemporal disease, with the alcohol-induced dementia, if they will stop drinking, many times they really appear to improve, especially with physical behaviors, social behaviors. Down at the bottom there, it's well established that alcohol use disorders damage overall health and well-being, and in fact, contribute to a shorter life expectancy by more than 20 years. With treatment and recovery, many of the ill effects of alcohol abuse are diminished, and patients can see a significant boost in their physical and mental health. And again, this is one we do have control over. Let's look at the malnutrition and vitamin deficiency. It kind of rolls in from the alcohol-induced. But a person who is malnourished or who has vitamin deficiency, there's different reasons why this might happen. We listed a few of them earlier. Some of the reasons that this might happen is because the person can't afford nutritious foods. If you look in the middle there, 1 in 4 adults over the age of 65 either skip meals or they have reduced meal sizes. Up to 60% of older adults in healthcare settings are considered malnourished, and they're placed. But they fall into the malnourished category. Now, this is something you may not know. A person can be considered malnourished and be overweight. We tend to think malnourishment is somebody who's underweight, but a person can be malnourished but be overweight. 715,000 US adults 65 plus are underweight, and then 1 in 3 US adults 65 plus are overweight. Let's look at the risk factors for this. The first one, number 1, reduced food intake due to mental health issues or poor appetite. I wish y'all could see my shirt. So May is Mental Health Awareness Month. My shirt today says, mental health, let's talk about it. I am a licensed professional counselor. I don't think I mentioned that at the beginning. Talk about mental health. And again, just like we might say, oh, let dad have his alcohol, let mama have her alcohol. We may just say, well, it's okay if they just eat Cheetos and sit there on the porch and have their bottle and are having their cookies and their, because that's what they like. And they're not eating anything like they should be eating. And then look at all of these other risk factors. Here's a huge one. Isolation. Isolation, living alone. Depression. Dementia is on there. Poor dental health. Alcoholism. So some of the effects of malnourishment and aging: muscles and bones. Just the aging body, we naturally have muscle loss and bone density, but malnourishment accelerates those losses. Healing and immune system: a lack of nutrition decreases our white blood count and makes it harder for the body to fight illness and to recover. Another thing that malnourishment does is it harms our organs and it harms our eyes, makes us at a higher risk for glaucoma. It harms our kidneys, which makes it harder for us to be able to filter. It can lead to dehydration, joint pain. It makes us have thin skin. It can make our nails really brittle and rigid, irritability and depression, and then how it affects the brain. Malnutrition. A loss of neurons that can lead to cognitive impairment. That includes loss of speech, poor coordination, memory loss, lack of concentration, disorientation, and apathy. And a person can get misdiagnosed with a dementia when what they have is malnutrition. Again, we always start primary care physician, because that can be reversed. So prevention and treatment: adjusting diet to make smart food choices, making sure we're getting all the nutrients that we need. We've put a resource on here called choosemyplate.gov, and the next slide is going to be a slide that you're going to want to run off if that is something you're interested in. If you're taking care of an older parent, a grandparent, an aunt, or an uncle, or if you just work in the field, this is going to be a great slide, the very next one. Making sure that we're staying hydrated, making sure we have plenty of water. Dehydration falls into the same category. Dehydration can also cause memory loss, so it can mimic dementia. Exercise helps build muscle and improve strength, and then taking care of our mouth and teeth. So here's that slide I was telling you about. You can get this on choosemyplate.gov, and you can actually run this off, and you can run it off in a size that's like a placemat. So it is great to teach with. And it used to, we used the food pyramid. Those of you that are my age and older, you remember learning about the food pyramid. And now we have this great visual here called choosemyplate.gov. So more tips on eating well, making sure we get a variety of foods to eat with all the nutrients that we need, making sure we have vitamin D, especially as we age. And the healthiest foods are whole foods. There is a diet that's called the MIND diet, M-I-N-D, the MIND diet, that was created by some neurologists. It's a combination of the Mediterranean diet and the DASH diet, which is high blood pressure diet, and it's specific to, it is supposed to be the best one out there about taking care of our mind. So the MIND diet is out there as well. It's finding other resources. There's Meals on Wheels. There's SNAP, Supplemental Nutrition Assistance Programs. We've got the Tarrant County ADRC listed on here. And again, we're going to have a whole page of resources at the end. Vitamin deficiency and memory patients. In a study, 40% of geriatric memory patients were deficient in at least one vitamin linked to brain health. And in 37% of those, it was B6. 33% were deficient in vitamin D. B12 was also listed. And then look at this. Similar neuropsychological deficits affect anorexic young women. Anorexic young women. But we'd never stop to think dementia with them, would we? Malabsorption of vitamins, fats, other critical substances. There's the niacin deficiency. And again, whenever we have a deficiency in that, it can show up as dementia, dermatitis, diarrhea, the 3 Ds. In the United States, it's mostly found in alcoholics and not consuming leafy greens, seafood, protein, and that is usually as a result of malnutrition. Niacin, which is vitamin B5, found in whole grain cereals, nuts, fish, meat. Symptoms are rapid loss of weight, diarrhea, fatigue, and sometimes even severe loss of memory. And let's talk about supplements. The best way for us to get vitamins and minerals is always going to be through food. Because most of us know this, the industry, the supplement industry, is largely unregulated. So we want to make sure that we're buying from a reputable source. When you look at folic acid is also essential to brain function and to emotional health. It's a component of DNA and RNA and used in brain cells in our central nervous system. And where we can find it is in dark leafy greens, spinach, chickpeas, pinto beans, lima beans, avocado, and whole grains. Some other supplements, vitamin B6, these are the very ones that whenever they did the research and they saw what was lacking in people over the age of 65, these were the ones that came up over and over again. Vitamin B6, and where you can find that, chickpeas, beef liver, tuna, B12, E, vitamin D. And then I want us to make sure and get to this Creutzfeldt-Jakob syndrome, because I've got a short video on this as well. And when I show you the picture of the brain, when you look at this, it's where abnormal proteins become toxic and they kill the neurons in the brain. And it creates holes in the brain that makes it look like a sponge. It's a very different looking brain than what we are used to looking at with other types of dementia. So if you'll look at this picture of the brain, doesn't look anything like those other types of brains that we're used to looking at when we look at frontotemporal Lewy body, Alzheimer's, vascular. This is what happens to the brain with this particular type of disease. So let's watch this. Again, this is another short video.
Creutzfeldt-Jakob disease is a rare degenerative fatal brain disorder that affects 1 in every million. It belongs to the transmissible spongiform encephalopathies family of human and animal diseases. The onset of this disease usually occurs at about 6 years of age, and 90% of sufferers usually die within the first year of having the disease. Creutzfeldt-Jakob disease is broken down to 3 categories: sporadic, hereditary, and acquired. Sporadic CJD is the most common and affects about 80% of the people diagnosed. There aren't any risk factors that can lead you to have this type. Hereditary CJD affects 5 to 10% of the people diagnosed and is caused by a genetic mutation. Acquired CJD is the least common type that affects only 1% of the people diagnosed. It is usually caused by exposure of nervous system tissue, including the brain, during a certain medical procedure. Early symptoms of Creutzfeldt-Jakob disease includes rapidly progressive dementia, problems in muscular coordination, changes in personality, impairment of memory, judgment, vision, and thinking, and depression and insomnia may occur. Severe symptoms of CJD includes mental impairment, myoclonus, which is involuntary muscle jerks, blindness, inability to move or speak, coma, development of infections such as pneumonia that can lead to death. Symptoms of CJD may be similar to those of Alzheimer's disease, but to accurately confirm the disease, an autopsy needs to be done because CJD causes a unique change to the brain tissue. CJD is caused by prions, which are harmless proteins found in human body cells. But once they become abnormal, they come together, which leads to neural loss, brain damage that is seen in the disease. The way the brain damage occurs is yet unknown. CJD can also be inherited. Prions can become infectious if mutation occurs in the prion gene, or if the prion gene becomes mutated in an egg or sperm cell that will ultimately be passed down to the offspring. CJD cannot be transmitted through the air or casual contact and is not contagious, but the disease can be transmitted by coming into contact with an infected person's spinal cord fluid or brain tissue. There are cases of people contracting the disease from cornea transplants, duramater grafts, implantation of unsterilized electrodes in the brain, and injection of contaminated growth hormones from the pituitary gland. The chances of contracting CJD through medical procedures has greatly decreased with the improvement of medicine. This time, there aren't any diagnostic tests that can diagnose someone with Creutzfeldt-Jakob disease. However, if a doctor suspects someone of having CJD, they'll administer tests such as spinal taps and giving the patient an electroencephalogram that will rule out treatable forms of dementia such as encephalitis and chronic meningitis. CT scans can also rule out brain tumors and signs of stroke. MRI scans of the brain can reveal the pattern of brain degeneration to determine if they're caused by CJD. Unfortunately, there is no way to treat CJD, but current treatment is alleviating symptoms for sufferers by prescribing them opiate drugs and sodium valproate for the myoclonus. Precautions that can be taken to prevent the spread of CJD includes covering cuts and abrasions with waterproof dressings, wearing face protection when coming into contact with splashing blood or spinal fluid, disposing clothes that came into contact with the patient. Avoid cutting or poking yourself with instruments contaminated with blood, soaking instruments that came into contact with the patient with undiluted chlorine bleach. Thank you for watching. If you like this video, leave a like, and if you want to see more quality content.
So here's more information on this one. And again, These are diseases that fall under the dementia umbrella. I said when we first started this, there's over 130 different types of dementias. And some of you may have picked up on this while you were listening to that, and it's on this one. Back in the 1990s, you remember the term mad cow disease? That's what this CJD is. It's the mad cow disease. In the 1990s, we heard about that in the UK, where some people developed it from eating meat from diseased cattle. And so we heard the term mad cow disease. That's what this is. The actual term is this CJD. And so it falls under the dementia umbrella. And that's why we are doing this. We're putting some of the lesser known, and some of them are very, very rare. Like this one is very, very rare. I will hope that in my entire career, I never see this. And hopefully I would never, ever, ever see it. But the alcohol-induced, I'm going to see. I do see that one. The malnutrition, absolutely, we see that. But this one, hopefully not. So these are some of the symptoms that occur with this one. Continuous changes, rapid decline, like within a few minutes, that type of a decline. Here's those references that I was telling you about. And again, you do have access to the slides, more references for help with alcohol and drug use disorder. There's our information, and my information is on there. I hope I left enough. Yeah, we've got a few minutes left. And let Marty talk about the CEUs one more time, and we'll talk about our next program we're going to be doing.
Sounds great. And there are several comments and questions. I guess there's some of the Q&A which I wasn't following. Hey, I answered one, but yeah, I'm going to go over the CEUs once again. Again, we're offering complimentary CEUs for licensed nursing, social work, LPCs, and certificates of attendance. The rules or the requirements for those are the same. You must complete the entire live webinar. You must complete the SurveyMonkey evaluation form. That will be sent out in a link in the follow-up email this evening, the first follow-up email. The SurveyMonkey evaluation form will be online and available for 7 days until the 17th. Please make sure that you complete it by that date. Once it's closed, it will not reopen. The certificates will be emailed to the email address you provide when you fill out the SurveyMonkey. And give them about 3 weeks. Actually, I want to make sure James L. West is kind enough to provide the CEUs, the complimentary CEUs for this. And so give them the time to get these out. It is very time consuming. So if you'll give them 3 weeks after the close of the SurveyMonkey, 3 weeks after the 17th to get them out. And then if you don't get it by then, if you'll just check, you can email me or email Jamie. Either way, it'll be just fine. And then the North Central Texas Area Agency on Aging, our organization, also has a Google survey for you to complete that is part of our tracking for our funding sources. That should pop up when you close out of your Zoom today, but I know there's pop-up blockers on a lot of people's computers, or especially if you're working for a company. That there will also be a link to that emailed out in the follow-up email. The first follow-up email will include everything related to the CEUs, and it will include the presenter slides, a link to the presenter slides, and the upcoming webinars we have. The second follow-up email will go out in about a week. That will have the link to the recording of today's presentation, and you're more than welcome to share that with anybody who might find it helpful. So Holly, do you want to go to the next one? And then, the next one coming up is on May 31st. The magic of reminiscing. I know it's, I don't know. I know it is reminiscing, but I have a hard time with reminiscence. And the DIY memory boxes.
Do it yourself.
Do it yourself. That's what I mean. So they're going to talk about obviously the importance of all that, especially when you're dealing with most of the dementias. You know, they're remembering a lot of things that were a long time ago. What they're not remembering is the more recent stuff. And so that's always great and important stuff. And so do you want to address any other questions that you've found, or you want me to?
Yeah, I have some of them that I can. There's probably some of them that I need to have them email me so I can send them some resources.
Great.
And somebody had asked, was that 3 months or 3 years on the Benadryl? That's 3 months on the Benadryl. Yeah, it is 3 months on the Benadryl. For those talking about where somebody with dementia who is an alcoholic can be admitted, you can email me with that, especially if they're needing some rehabilitation. There are some, and it kind of depends on where they are in that moment. Sometimes they may go to a rehabilitation hospital as like a rehab, not a to dry out rehab, but like I need physical therapy type of something, and they can kind of start the process through that. Most of the time they will end up on some medications to help them while they are going through, especially if they have been drinking for a long period of time. We are not just going to cut somebody off all at once. We're going to use medications to help them come off of their alcohol. It is very different coming off of alcohol whenever a person is over the age of 65 than if they are 28 or 33. And we also have to look at comorbidities. Also, that's another thing as well. Now, people were talking about a person having 1 or 2 drinks. That's very different. 1 or 2 drinks is very different from 5 or 6 or finishing the bottle or 2. I have worked at places where we allowed residents to have a drink with dinner, and that's all right. There's nothing wrong with that. If that person was an alcoholic, then we don't want to do that, but that's why we have free wine, and that's why we have the non-alcoholic beer, and that's why we have I've used that forever. When I was in the day program, we had opening day, baseball day, and had all kinds of beer over there. And it was all a non-alcoholic beer. Looks like beer. It's in a beer can, or you pour it in a frosty mug and it's beer, and we call it beer. But for those of you who were needing some really specific information, please email me. My email is on that last slide. If for some reason I do not get back with you, like Marty said, lots of times there is it will catch it. You can also call me and let me see if I can get you some information. I will always get back with you, but if for some reason I don't, it was caught in my filter somewhere. So you can also give me a call because I do have some information for you, because there are several of you that sent me some like some private things. So please do send me an email.
Do you have the placemat? I know it's in the slide. Is that a link to a site?
Oh, what did I do?
No, you're good. You're fine.
Yeah, that was, and it's on that particular slide.
I knew it was on this. Oh, the link is the address. I'll find it.
Choosemyplate.gov.
Okay, great.
Myplate.gov. Yeah, it sure is.
I'll go back and find it. I'll include that link in the follow-up email as well, along with the link to the PowerPoint.
It has some where you can use it with different, like if you are teaching adults or you are teaching children, and so they have it for different age levels.
Nice.
So it's age appropriate.
Yeah.
So if you're teaching a class, it's age appropriate.
Very good. Very, very good. So,
and it's a user-friendly site.
Nice. So if any of you have questions that didn't get answered, if you'll please email me or email Hollie, I'll forward them to Hollie, or email Hollie, either way, and we'll try to get back to you on that. We only had an hour. We're already a couple of minutes over. So we'll look for you guys to do that, to email them to us. And like I said, we'll get them somehow. Either I'll get them to Hollie or she'll get them back to you. Thank you.
Those questions in the Q&A, please do get with me. I do have some resources for you. And if it's something I don't have, I will get it for you. I will find it for you. I've got a lot of good resources here. So please, please, please get with me. Get with me or get with Marty.
Great. Thank you, Saul. Thank you very, very much, Hollie. Thank you so much. Once again, incredible presentation.
Thank you. Thank you.
Thank you all for joining us. Please look out for our next webinar.
See you
and
next time.
Share the good information.
All right. Bye-bye.
Take care. Bye-bye.